action in the early years for health and reducing health inequalities, and then move on, as Michael said, to a programme that we've been involved in with the healthcare system, which isn't our usual entry point for work on key social determinants of health, but I think has a lot that we're learning from it. So to begin with, a reminder, the 8 Marmot principles, which are all highly interrelated, and you at Coventry will know that as well as anyone. So we're going to start today with giving every child the best start. And just to reinforce the point that early years are where inequalities begin to set in and show, even in the earliest years, maternal health, infant health, but it's also the area where action to reduce inequalities can be most effective. So for all these reasons, it's always been a priority area for us, but of course, interrelated with all these other areas as well. So we see inequalities in health, in maternity, in infant health, and very clearly in early child development. And we know pretty much, not completely, but we've got a very good idea about how you can reduce those inequalities. And of course, that's through action on the social determinants of health and through services. So maternity and early years services, children's centres, speech and language, etc. So a lot of the work that we do in places is around supporting maternity and early years services, focusing on what they can do to support the whole family, reduce inequalities in other social determinants of health, as well as tackling immediately those inequalities in health. That involves support for parents, of course, and parenting, thinking about income, absolutely critical, much harder and less likely to grow up healthily in a household with low income and in poverty, the stress that's associated, the lack of access to resources, etc. So we think about how to increase pay, access all the benefits and types of support which are available. And we know that not all support which is available, which is quite minimal, but what there is available is not always taken up by families who would benefit the most. So focus of our work with places is trying to encourage access to the support that's available. And then, of course, thinking about the environment, the air pollution, safety in access to green spaces, all those issues which really affect and impact young families, young children and babies. Housing, the quality of housing, the affordability of housing, of course, these are all having a big impact on people even in the earliest years, and then that transition to school. So there are many other areas as well, which have an enormous impact on early childhood, and through that later health. Perhaps the starkest inequality, infant mortality, just to illustrate the wide inequalities. This is the poorest decile, poorest 10% of households in England, and that's increased again. So you can see how much more likely infants are to die in this poorest 10%, and those inequalities with the wealthiest, the least deprived neighbourhoods here. So some really stark inequalities set in. And when you look at, last time I was with you for a webinar, I was talking about structural racism and inequalities. And in fact, I think I showed this graph, but you'll be familiar. Maternal mortality rates by ethnicity in England, 3 to 4 times higher for Black women than for other ethnicities. So really stark ethnic as well as socioeconomic inequalities in maternal mortality rates. And this has been attributed partly to the issues around socioeconomic deprivation, but also issues with maternity services themselves, sometimes lack of cultural sensitivity and appropriateness, stereotyping, bigotry, and outright racism. So we can see these very stark inequalities here, and these have persisted for a long time. So particularly galling, we've been aware of them, and they're still not being reduced, or only slightly. Infant mortality rates, when we look by ethnicity as well, you can see these really stark inequalities. By ethnicity, white groups here with much the lowest rates of infant mortality rates, and Indian right up again to some of the black groups with those highest rates. So again, that's partly about conditions for in gestation and in maternity, but also about the services. And we know that there, even within places, very stark inequalities, partly related to socioeconomic, also ethnic composition. This is low birth weight babies within Leeds. So you can see enormous differences. And this kind of data is not just showing us the extent of the issue and what the issue is, but how to direct support and help into those areas, those neighbourhoods. These are wards, at ward level, where you see these much worse rates. So the more fine-grained data that we have can really help direct programmes. So often services, especially with the NHS, are provided universally, which is great, but we need to ensure, first of all, that they're appropriate, and secondly, that they're reaching these communities where they're needed more. And that may mean more intensity, greater resources for these lower income neighbourhoods and some of those ethnic groups. So just to be clear that when we work with places, we talk about universal services which are targeted in a way which is proportionate to the scale of the issue. So less here, more here. And very stark in terms of infant mortality, maternal mortality, infant low weight, which then has repercussions throughout life, actually. Also developmental concerns. This is in Scotland, across Scotland, and you can see here we've mapped out deprivation, the more deprived local authorities here, Glasgow City, and developmental concerns. So there are much more higher levels of developmental concerns in poorer, more deprived local authorities. And when we look within each of these local authorities as well, we can see those inequalities. So within Aberdeen City, for example, even though it's got fairly positive levels of developmental concerns, i.e. low levels, within Aberdeen City, there's a big gradient in wards as well. So we know that these profound inequalities in a whole range of experiences and attributes in the early years, and these have enormous impacts throughout life. So here you can see adverse health and educational outcomes following early childhood disadvantage, much more likely among those in deprivation. So all the children followed here had early childhood disadvantage or adversity, but you can see the impacts much greater throughout life in the more deprived neighbourhoods and for those families in greater deprivation. And this runs through health directly, but also other social determinants of health. So if you're born in a deprived household, in a poor area with lack of access to resources and so on, you're more likely to have lower educational attainment, worse employment prospects, and all of that also affects your health. So the impacts are cumulative throughout life. So what have we been doing about it? Unfortunately, going in the wrong direction here in the UK. This is a direct result of national policies and investments. So you can see here change in child poverty rates increased in the United Kingdom, the greatest increase of all these countries. Poland, Canada, Ireland all managed to reduce child poverty. Unfortunately, the UK, Norway, France, Germany, it's increasing. Some very stark national policy decisions which have impacted children very negatively. And of course, that has impacts. This is children in relatively low income in Leeds again. You can see these enormous differences and growing inequalities within Leeds and by ethnicity. And I think I did show you this last time. I'll show it again because it's such a stark graph. This is London, rates of child poverty, percent of children living in low income households by ethnicity in London. And you can see lower rates, Chinese, white, Indian, much higher rates, and really incredibly high rates among Bangladeshi, Pakistani, other Asian and Black households, well over 50%, up to 70% plus among Bangladeshi and Pakistani households in London. So we really need to look at differences by area, differences by socioeconomic group, and differences by ethnicity. And again, that helps us think about what we can do to reduce poverty in the early years successfully, targeting and investing proportionately more. We know that child poverty is rising. It's high in England and rising. It's gone up since this graph, 2019-20. Scotland and Northern Ireland. Northern Ireland's actually managed to reduce its child poverty rate despite all the countervailing forces which are pushing towards increasing child poverty. And Scotland, again, they've done even better than this graph shows in reducing child poverty since 2019-20. England, on the other hand, and Wales, these really alarmingly high rates of child poverty, the result of decisions made nationally. And it's very expensive. We just outlined in terms of health for the children who are affected, but also to the country as a whole, because of loss, additional spending, which is incurred as a result of child poverty, to health, to education, criminal justice system, etc., tax loss to governments. I mean, these are enormous sums annually, and you can see that the estimated costs have increased since 2013 up to nearly 40 billion, estimated in 2021. So it's not that we're saving money by reducing resources available for children and families. We're actually just pushing the costs onto another part of the system and onto society as a whole, as well as those family and children. And this is a comparison of what countries spend on early child education and care. You can see enormous differences. Luxembourg, very wealthy, but has the highest rates. Iceland, Norway, you might expect. You come all the way down here. This is the EU and OECD average, and down we go, right down to the United Kingdom here, spending much less than similar countries on early child education and care. And that has really damaging implications in terms of future generations' health, well-being, the economy, work, income, and so on. So there's a strong case for national government to allocate far more to young children and families in these earliest years, and begin to increase this spending up to the rates of France, Finland, Korea, Germany, up here, or even to the Nordic countries, right to the left of this graph. Unfortunately, this has not been happening. And we know that there's been cuts in national government spending generally, but here the allocations from national government to local government, Coventry somewhere on this graph. So this is everywhere. All these places, all these local authorities have had a significant decrease in funding since 2010 to 2012, as you're painfully aware. Many places more than 50% cuts in their funding. This is mapped against life expectancy for males in 2010. So you can see those areas that had the lowest life expectancy down here have received far greater funding cuts than those areas which started with higher life expectancy. They've still experienced cuts, just far less. So places with male life expectancy around 82 had 20 to 30% cuts. Down here, life expectancy was nearly 10 years lower and had 50% cuts. So of course that's reinforcing the disadvantage, the deprivation, the worse health in these places. And we really want this graph to run the other way, so that increases in funding are diverted to those areas which are most deprived. So these resource allocations really matter. They matter from national government to local government, of course, as we've seen here, but also within places, they matter. Are we reaching families at the right time? Are we reaching the right families more can be offered to those who need it most. And that's an investment for the whole place and for the whole of societies. So when we work with places, we talk about embedding equity and children and young people in every commissioning decision. When you have to decommission, are you decommissioning services in the right places? We're currently working with one place where they're trying to shift funding for family hubs from a wealthier area into a more disadvantaged neighbourhood, and running up against all kinds of opposition. Nobody likes having things taken away from them, but it's really important that we think about equity in all these decisions about what funding and what services we can still commission, and where they're placed and who they're reaching. So that relates to this point about proportionate universalism. I've mentioned about resource allocations, but also about service design and delivery. Are we reaching those families we really need to? Very important, of course, and I know you know this in Coventry, that the views of parents, children, young people are included. And I'll come on to an illustration in a moment about how they changed some of the work that we've been doing with the healthcare system when children, young people were giving the opportunity to articulate what they felt was influencing their health. Support for parents, it's so important. It's not impossible, of course, but it's much harder to parent in a positive way when faced with all the adversity and challenge and mental strain and lack of access to resources when families are in poverty. So support for parents is absolutely vital, of course. And then these partnerships with the community and voluntary sector and businesses. Businesses can do a lot, and in fact a lot more, we think, to support families, partly through their conditions of employment, maternity leave, paternity leave, and so on, through their social value within a local place, and how much of that is directed towards children and young people. And then I mentioned earlier about uptake of benefits. We know there are big inequalities even among those who are eligible about who are getting access to these benefits and vouchers, and that's a really relatively straightforward thing for local areas to do, is to encourage and support people into access to those benefits. So I'm well aware that Coventry does many of these things, but as an illustration, we want national action, of course, but there is plenty that a whole range of partners locally can do to support families and young people and help reduce adversity, disadvantage, discrimination, and poverty. This includes, of course, the healthcare system. So we've got this partnership with Barnados and 3 integrated care systems and children and young people themselves to think about what a healthcare system would look like if it was directed towards supporting children and young people in the ways in which they're living and their social determinants of health, as well as, not instead of, but as well as ensuring good quality services and access to those services and so on. So we've developed a framework for the healthcare system, setting out the key drivers of health and well-being. And we've made the case to the healthcare system as well that if this is done, it will help reduce demand on services. If you think about demand for mental health services, even asthma and respiratory clinics, a whole range of different healthcare services, currently huge demand on them. But if you intervene earlier, proper sense of the word prevention in those key social determinants of health, it will support the efficiency of the service as well as benefiting communities and improving their health. So we had several purposes for the work that we've been doing with these 3 integrated care systems and Barnados. And the third, to support and guide the integrated care systems in the commissioning and development of intervention and services to improve children and young people's health and well-being, has really been the purpose. So we do have these 3 programmes running. That's required really strong partnerships between the healthcare system, local government, and the community and voluntary sector, and business as well. I'll come on to it. So it's really strengthening those partnerships, which are a big focus actually of integrated care systems purpose, as well as improving health and tackling health inequalities. So we started with a framework which is well evidenced and we've used many times before, showing the main drivers of health, relates to those Mama 8 principles, but it sets out those key social determinants of health and the kind of pathways which lead to worse health and well-being for some groups. And then we did this Barnados ran this big engagement exercise with children, and it changed the framework actually, because they were telling us things which aren't well captured in data or in evidence that were really affecting, they felt, their homes. And interestingly, they didn't mention poverty or lack of money, but they talked a lot about relationships, particularly with their family and friends, but also teachers and people, service providers that they came across. Feeling safe was a very strong component of what they felt was affecting their health. And by that, they meant feeling safe at home. So safe from physical and emotional abuse at home, of course. Also feeling safe among their friends and in public places, at school. And what can schools do to support this? And children were feeling very much unsafe, and that was affecting their mental and physical health in a whole range of ways, not attending school, not wanting to go outside the home, or feeling that school was the only place where they could feel safe. So it provided some really helpful insights into what the healthcare system might look at if they were looking at supporting children's health upstream. And it's not well captured. Any of those things are not well captured in data systems or monitored. So it was very helpful having this partnership with children and young people to inform this framework. So we came up with this framework. So box one is really those big political drivers, which I've outlined earlier: financial decisions, tax and benefits, etc., cultural and societal norms and values. That was considered outside the remit of the project. Inside this red box, all these areas were felt as there were areas where the health service could helpfully intervene to support children and young people. So what could they do to support better outcomes at school and in education, in employment, family income, wealth and poverty? This is obviously well outside the normal areas that the healthcare considers within its remit. But there are ways in which they can influence all of these. And then these living conditions where children are living, relationships at home, with the family, community, places, safety. And I'll come on to some of the things which the ICS have done to try and strengthen outcomes for children and young people in these areas. And then there are these personal characteristics and intersectionalities, protected characteristics and so on, which really affect children's experiences and likely outcomes in all these areas. And then finally, interactions with the systems and services. And we had quite a challenge getting our 3 ICS to understand or think through what they could do in these areas. So we thought, you won't be able to see the detail on this, but we thought about starting on the right-hand side of this with a specific health outcome. So we started in this example with asthma, and then thought about what the health service could do in all these areas to improve and reduce hospital admissions from asthma. And that was around, advocacy for clean air, healthy environments in schools, to adherence to treatment pathways and so on. So it was just a way of illustrating to the healthcare system that if they want to support health and better respiratory health, what can they do in these areas? And another example that we used, again, you won't see the detail, but these slides will be available to you. This was around improving readiness for school. So what can the healthcare service contribute to strengthening and reducing inequalities in readiness for school? And then the 3 integrated care systems thought through what they might be able to do. So to support these key social determinants of health, Birmingham and Solihull integrated care system have doubled the social value contribution in all their procurement. And that's an enormous system. I think they spend £1 billion a year. So increasing social value in procurement from all the providers who provide services, or bin liners to the NHS. So they've increased the requirement for social value contributions from 10% of all contracts to 20%. And that additional amount is intended to be invested in community and voluntary sector organisations aimed and oriented towards children and young people. And the local authorities at Birmingham and Solihull have a system set up and good relationships with the community and voluntary sector organisations. There's some quality assurance, and the Birmingham and Solihull NHS, the Integrated Care System, are working closely with those two local authorities to direct the funding that they're generating from this increase in social value. So that feels like a really significant, substantial system change that's actually generating resources for these community and voluntary sector organisations. Cheshire and Merseyside took a different approach. They've noticed that their early years inequalities, early years development and readiness for school are really wide, and they wanted to contribute more towards reducing those inequalities in readiness for school for babies and young children. So they've worked with the Dolly Parton Foundation, which supplies books and communication materials, supporting young parents to really communicate, tell stories, read where they can read. There's not some of these young mothers are unable to read, but then to tell stories and communicate and just sort of interact with their babies and young children. So again, this may be something that charities, community and voluntary sector, and indeed the local authority are doing anyway. But the innovation here is that we've now got the NHS involved in this programme and really supporting where they can with this. And all the materials are provided by the Dolly Parton Foundation. It's a very nice programme. And then in South Yorkshire, Integrated Care System, they've developed a programme with Rotherham Football Club targeting specifically, I think it's 9 to 10-year-olds who are not attending school, suffering with anxiety, don't want to go outside the home and interact. And obviously their educational outcomes, but also their whole development is suffering as a result. So they've set up this programme. It's obviously Rotherham Football Club is great. And they've got this youth programme now with these 9 to 10-year-olds who've been identified by schools, and their families and the children join this programme, and then it's just for the children, and they give them coping strategies and life skills. They have lots of fun things that they do. Basically a good youth club. But again, the innovation here is around this system change with the integrated care system taking a very active role in the development and commissioning of this programme of Rotherham Football Club. So, three very nice examples of the healthcare system really taking action upstream and in prevention. We hope that this programme, and we think it is informing the healthcare system in England generally. NHS England are on the board that we've set up for this group. But really to get the NHS, all healthcare parts of the healthcare system, to think about the drivers of ill health as well as their main job, of course, of treating ill health. But we can make a strong business and efficiency case, we think, for them to take this more upstream approach. It's really highlighting the inequalities in these drivers of health for children and young people through that framework, and emphasise the importance of involving children and young people. We've got a data tool that strengthens these partnerships, but as I said, the data tool is not well set up to capture the views of children and young people, so that's an additional requirement really on the NHS and local government to take in their views. And we think that should be national and global interest in this programme. I'm about to finish this, but just to say the programme's still ongoing. It's due to end, I think, this first phase at the moment the whole programme is due to end in October. We've got quite good learning and knowledge exchange around this. We're running 2 evaluations, one on the 3 programmes. So what impact are those 3 programmes having on the health and well-being of children and young people, but also the system change more broadly. Carrying on working with the LGA, Local Government Association, and the NHS, and thinking about this kind of work, what else other integrated care systems might like to do in this space. I'll stop sharing. That's my run through our focus, I think, on why giving every child the best start in life is our priority area, and hopefully some thoughts about how different parts of the system within a place can take action